Nico Martinez, I think, from Seattle, who's going to be talking about fostamatinib. Slightly vague. We're not quite sure. I'm not quite sure the second name, but I think it's Martinez. Is that right? Nico Martinez, who's. So what time is it in Seattle? Must
Hello,
be
it's
yeah, like
3:40 a.m.
4:30. 8 hours behind. 9 hours behind. Okay, 9 hours. Yeah. He's there. Okay, that's Nico, can you hear me?
Yes, can
Yeah,
you hear
hi.
me okay?
Hi. Thank you. And you're going to be talking to us about fostamatinib, your experience of fostamatinib.
Yes, I'll be
Yeah, okay.
presenting fostamatinib, and then there's also someone else talking specifically about ITP, Sangbi. So we'll
Oh,
be talking
okay.
together.
Okay, you're free to start if we have your presentation.
Yes, let me share my screen. And my last name is Ruiz. Nice to meet you, everyone.
Your
Uh,
second name is Louise? Louise, not
my
Martinez.
last name Ruiz. Ruiz.
Oh, really? Okay. Okay, that was I blame Thomas for that. So- yes, it's all your fault.
Okay, can you see my slides?
Yes, yes, we can.
Okay. Well, thank you everyone for having us. Hello from Seattle. It's pretty dark here right now, but happy to join and share our experience. I've been working under the mentorship of Dr. Sandhya Panch, who you may have heard yesterday. She is our expert here in autoimmune cytopenias at Fred Hutch. And this is a project that I started with her on my first year of fellowship. I'm currently a third year hematology fellow. Um, and this is titled The Efficacy, Safety, and Molecular Response Correlates of Fostamatinib in Warm Autoimmune Hemolytic Anemia or Evans Syndrome, a multicenter analysis. So maybe we're a little bit off target with the warm autoimmune hemolytic anemia, but we will talk a little bit about Evans and some of the other interesting findings that we've had. So fostamatinib is a spleen tyrosine kinase or SYK inhibitor of macrophage-mediated red blood cell and platelet destruction, and it is approved for chronic immune thrombocytopenia or ITP. Currently, there's no other FDA-approved therapies for warm autoimmune hemolytic anemia or Evans, and we know that steroids and rituximab are standard. Fostamatinib is pretty well tolerated, but can cause hypertension due to off-target effects. There's a recent phase 3 randomized controlled trial, the forward study, where 36% of patients with WAHA achieved a durable response with fostamatinib, but they failed to meet the primary endpoint, so they did not receive FDA approval. Interestingly, the data were discrepant, and a post hoc analysis showed that the Eastern European cohort had a higher response in the placebo group. And so there seems to be, after reanalysis, a 40%, a 35% response in the fostamatinib group compared to about 10% in the placebo. So otherwise, published real-world data on fostamatinib is quite limited, and based on the experience at our site, and given that there's no FDA-approved therapies, and the discrepancies that sometimes can be seen between randomized controlled trials and real-world data, we decided to do a real-world, multi-center retrospective analysis to evaluate the safety and efficacy of fostamatinib, as well as we did immune profiling in a subset of responders and non-responders at our site. So, to understand a little bit of what we did, we screened patients across 6 U.S. sites. I've included here on the map so that you can see the sites. Um, our site contributed with the majority of patients. This is University of Washington and the Fred Hutch Cancer Center, but we also had Mass General Brigham, Montefiore, Levine Cancer Center, University of Vermont, and University of California. Out of 102 patients that were initiated on fostamatinib between 2016 and 2024, 79 were excluded, the majority because they were given fostamatinib for ITP or immune thrombocytopenia. And 8 of them had received fostamatinib as part of the phase 2 or 3 trials. With that, we have 23 patients left, and one had received fostamatinib for less than 8 weeks. So we ended up with a total patient count of 22 across the 6 sites. And we decided our outcomes were to assess response, which we defined as a hemoglobin above 10 grams per deciliter or an increase of more than 2 grams per deciliter from a baseline on 2 consecutive visits, and a durable response, which was defined as a hemoglobin above 10 at a 6-month cutoff. Secondary outcomes included changes in corticosteroid dosing, concomitant therapies, red blood cell transfusions, hospitalizations, blood pressure changes, and other adverse events. And in the subset of patients that were enrolled at our site in an autoimmune cytopenia registry and repository, we performed additional testing for inborn errors of immunity and transcriptomics, cytokine, and RNA sequencing. In terms of the results, I'll go through these quickly because I think you might be more interested in some of the molecular data that we have. Um, and as you can see, this is the manuscript still is in review. We have not published yet, but we saw a response in 13 out of the 22 patients, so almost 60%. Um, the 60% of the patients had warm autoimmune hemolytic anemia and 41% had Evans syndrome. The mean age of diagnosis was 51 years. And our demographics here, you can see 64% were female, 68% were white, but we had 32% of Hispanic ethnicity. And we mentioned this because anecdotally at our site, these patients were noted to have a better response to fostamatinib. The 9% of patients had a history of venous thrombosis, and 32% had a history of autoimmune disease. And that included thyroid disease, antiphospholipid syndrome, lupus, as well as rheumatoid arthritis. And all patients had a median of 3 treatments before fostamatinib. This is excluding splenectomy. 100% of the patients had received glucocorticoids for treatment, and 21 of the 22 patients had also received rituximab. And then there was a whole combination, as you may expect or may have had experience with these diseases. The patients had been on different treatments, including mycophenolate, azathioprine, danazol, cyclophosphamide, among others. Adverse events with fostamatinib occurred in 5 patients of the 22, so about 23%. We saw 9% having gastrointestinal symptoms, mainly diarrhea and abdominal pain. 9% had hypertension, and 5% had severe neutropenia with an absolute neutrophil count of less than 500. The discontinuation was documented in 2 patients, 1 patient for neutropenia and 1 patient for hypertension. And we did see a significant mean increase in the diastolic blood pressure of about 5 millimeters of mercury. But we didn't see any differences statistically between monthly emergency department visits or hospitalizations pre-fostamatinib and post-fostamatinib. I should have mentioned that the data that we reviewed retrospectively was from 3 months before fostamatinib start to 6 months after. You can see here some graphs depicting the efficacy of fostamatinib. Overall, we had a 64%, we saw a 64% overall response with a 46% durable response. As you can see in graph A and B, graph A, you can see the median hemoglobin, and this data was graphed similarly to how it was reported in the randomized control trial, the forward study. Median hemoglobin, as you can see in blue, are the responders compared to red, the non-responders. You can see the median hemoglobin and how after 4 weeks you can see both curves separating, and in the gray area, it's the normal ranges of hemoglobin. And then the median change of hemoglobin is depicted in panel B. And you can see that both groups had an increment in their hemoglobin, and that is because despite patients not responding to fostamatinib, they were started on other therapies or they were still getting transfusions. LDH data and reticulocyte count, as you can see, is quite variable, and these are part of the limitations of our study. This is a retrospective analysis, so data collection is challenging. There's differences across sites, and there's patients, including some at our sites, that are only come to our center for a second opinion or are peripherally followed. And so if they are followed at other institutions, maybe transfusion data is not accurately reported. And just to summarize here, 14 patients of the 22, or about 64%, responded. And interestingly, this included 3 patients who had a prior splenectomy. So it speaks of fostamatinib having, some of these protective effects aside from the splenic sequestration or phagocytosis. So it also is blocking phagocytosis in the reticular endothelial system or in the liver. The response was durable in 10 patients of the 22, so about 46%. And if you remember, the durable response was defined as a hemoglobin above 10 at a 6-month cutoff. So this is slightly higher to what was reported in the randomized control trial. The mean time to response was about 3 weeks. Prednisone was tapered to less than 20 milligrams daily in 16 patients, so 73%. But some patients did require rescue steroids afterwards. And the patients requiring transfusions decreased from 45% at the beginning of fostamatinib use to 18%. But as I said, the transfusion data was not accurately reported in all sites. And interestingly, more Hispanics were among the responders compared to non-responders. 6 of the 14 um, responders were Hispanic compared to 1 of the non-responders. But these are small numbers, but it was not statistically significant. Then some of the other interesting molecular studies that we did. So we did transcriptomic analysis using a nanostring gene expression panel. This was done from fresh mononuclear cells. We also did cytokine and chemokine analysis using a bioplex human cytokine screening panel, and this was done from supernatant plasma stored and cryopreserved. As you can see in panel A, this is the fold change of differential expression in genes. And so you can see here the genes that were upregulated in pink or downregulated. And so what you're able to do then, as you can see in panel B, is you can classify or cluster these genes based on the biologic pathways that they're involved. In red, we have 3 patients that were, this is all at our site. The 3 red patients over here are the non-responders compared to 5 responders that are depicted in blue. And as you can see, the responders had an increased expression of genes related to Fc receptor and phagocytosis signaling, as well as NF-kappa beta signaling. In panel C, you can see differences in cytokines and chemokines. In blue, you see the responders compared to the red triangles, which are the non-responders. And there's differences in some cytokines, but the main difference was seen in the macrophage migration inhibitory factor levels, which were higher in the responders. Of course, the caveat is that these samples were collected on patients that were already started on fostamatinib. They had been on fostamatinib for at least 4 weeks. And some of them were also on concomitant steroids, mycophenolate, or azathioprine. So some of these signatures that we're seeing, it's hard to say if they were predictors of response to fostamatinib or if they were expected results from fostamatinib. But what's interesting is that we were seeing differences between responders and non-responders. Here you can see distinct cell populations that were identified via single cell RNA sequencing. And the proportion of clusters and surface markers among responders versus non-responders. Here we could only include 2 of the non-responders because one of them was an inadequate sample for doing the RNA sequencing, the single cell RNA sequencing. So in panel D, you can see the different cells populations that were identified thanks to the RNA sequencing, and the proportion of these are depicted in these bars, responders compared to non-responders, and you can see the color code here. What's interesting to note on panel E is that there's different T lymphocyte and monocyte surface marker expression. And as you can see here, we've clustered them. The non-responders are red and the responders are in blue. And there are some differences in the surface marker expression. And interestingly, what we noted in this group in number 6 is that there's M1-like activated inflammatory monocytes in the responders. And so this means that despite the use of fostamatinib, these patients have an activated kind of inflammatory monocyte type, and this could correlate with patients that are more likely to respond to fostamatinib compared to non-responders. Here, there's some more additional correlates comparing. So it's similar findings as what I previously described, but we're comparing this to healthy donor controls that are sex matched. And so those are depicted in gray. And oops, excuse me. And so as you can see here in panel B, we have differences in Fc receptor and phagocytosis pathways, as well as NF-kappa beta signaling. And in general, similar with the cytokines, the overall conclusion that we saw is that the responders, which are depicted in blue, seem to have similar pathways or cytokine levels as healthy controls, while non-responders, as you can see here with the red triangles, have differences both in this gene panel expression, but also in some of the cytokine levels. And so there's something that's telling us that non-responders have an aberrancy and something that could help us predict if they're not going to respond to fostamatinib. In these panels underneath, these are single-cell RNA sequencing, including healthy donor controls. And what's interesting in panel E, where we've included the healthy donors in gray, is this population that was identified of based on the T lymphocyte surface marker expression. We've highlighted here, this is a TEMRA population, which stands for terminally differentiated effector memory T cells, or TEMRA cells. These were noted in the non-responder.
Sorry,
Yeah.
Nico, we're kind of out of time. I think we have to wrap up very soon, if you don't mind.
Okay, I'm sorry. I thought I was told I had 9 minutes, but yeah, I went over. So I just want to conclude here that these TEMRA cells, um, they are T cells that have expanded due to chronic stimulation, aging, or concomitant autoimmune disease. And these are the ones that could probably contribute to the refractory disease. These are some other testing that was done, as there were no differences really in inborn errors of immunity or somatic testing. And these are the conclusions here that you can see. I just wanted to highlight the findings that we saw. Interestingly, more Hispanics were among the responders, and that correlates with what has been described in the ITP studies from Spain. Sorry, I went over time, but thank you so much for your attention.
No problem. Thank you so much. I think what we're going to do is we're going to go straight. Sorry, you can clap. You can clap. I think